Hello, I'm Norman Swan. Welcome to this program on bipolar disorder, and it's coming to you on the Rural Health Channel 600. Bipolar disorder affects approximately 2% of the population, but as you'll hear, hidden in those figures are very interesting statistics which suggest that some forms of bipolar disorder are actually quite common. But it is poorly diagnosed, resulting in lengthy delays before effective treatment is commenced. The impact of bipolar disorder on people with the condition and those around them can be enormous. So it's essential that there's early diagnosis and management. Another important problem associated with poor diagnosis is that potentially dangerous medications are started inadvertently. Today's program looks at how better screening can assist diagnosis, the latest recommendations regarding medication, and the importance of a multidisciplinary team approach to providing better treatment outcomes. This is a professionally accredited program from the Rural Health Education Foundation, and more information about the channel can be found on the Foundation's website, rhef.com.au. As with all our live programs, we'd love to hear from you, your questions, and we'll put them to the panel. You can get in touch by phone, text, email, or fax. The details are now on your screen. You can send your emails to questions@rhef.com.au. You can text us to 0408 408 932, only polite texts please, or phone us on 1800 817 268. You can also fax your questions. Does anybody use a fax anymore? If you do, you're welcome to send a fax to 1800 633 410. As usual, there are a number of useful resources available on the Rural Health Education Foundation's website, rhef.com.au. But now let's meet our panel. Dr. Mike Beckhoff has been a rural procedural GP for 35 years and has worked at the Bridge Clinic in South Australia, specialising in mental health, men's health and sexual therapy. Welcome, Mike.
Good evening, Norman.
Mike's currently clinical advisor to the Country Health South Australia's local health network and is on the ACRIM board as the South Australian director. Lynn Byers is a remote area nurse practitioner currently working on with the Mark Sheldon remote mental health team in Alice Springs. Welcome, Lynn.
Thank you.
Prior to this, Lynn worked as a remote area nurse in Indigenous communities in Central Australia for many years. Tim Carey is a clinical psychologist. He's worked in psychiatric hospitals, adult correctional facilities, community mental health settings and private practice. Welcome, Tim.
Thanks, Norman.
Tim is currently Associate Professor in Mental Health at the Centre for Remote Health in Alice Springs. He's developed a transdiagnostic cognitive therapy called the Method of Levels, MOL, and is not nearly as complicated as it sounds, and it's quite fascinating. In fact, you'll hear about it later. Paul Friend is Clinical Director at the Black Dog Institute in Sydney, is a VMO psychiatrist at Albury-based hospital and the Deniliquin Community Mental Health Team. Welcome, Paul.
Good evening, Norman.
Paul also visits Tamworth as part of his Black Dog work. He runs a private psychiatric practice in Sydney and has done so for 22 years. Daniel Rifkin is a pharmacist with experience in urban and rural communities. He's currently working in the Blue Mountains area outside Sydney. Welcome, Daniel.
Good evening, Norman.
Daniel is also completing his PhD in how pharmacists can work as part of a healthcare team. Daniel is the recent winner of the Australian College of Pharmacy Young Pharmacist Innovation Grant. Congratulations.
Thanks, Norman.
Tell me about the innovation.
Mainly involving young pharmacy students and mentorship and getting involved with clinical roles.
And what's your interest in mental health as a pharmacist?
As a pharmacist, we see patients with mental health every day, every hour. So we have a role to help with the adherence of their medications, and it's that passion that has driven me to get more involved in mental health.
So Paul, you and I grew up being taught about manic depressive disorder. They don't use that anymore. It's kind of called bipolar disorder. Just take us through it. The definition, what is it? We've got some graphs to go with it.
Well, manic depression is what we now call type 1 bipolar disorder. The severe form of bipolar disorder where you can have prolonged periods of elevated mood and prolonged periods of depressed mood, and at least at times that can reach the intensity of being psychotic, whether you're elevated or depressed. Not necessarily every time, but at least sometimes. Type 2 bipolar disorder is...
Well, before you get on to type 2, so I think people are familiar with the sort of things that can happen in terms of the really life-disrupting things that can happen when you've got an elevated mood and you've got delusional behaviour. But talk to me about psychosis with depression. Because people talk about this as being the blackest depression you can ever imagine.
It certainly is. And when you are psychotically depressed, you have delusional thoughts, you may have auditory hallucinations, but fundamentally you have beliefs that are completely untrue. It can be that you have a life-threatening illness like cancer. It can be that you believe you've committed crimes, like you've murdered people or committed fraud and you deserve to go to jail, you deserve to be punished. Or it can be that you believe that you are financially ruined and destitute.
Which might be true, actually.
Which may be true, but mostly is not.
And people fear this depression. I mean, once they've experienced it, they're terrified of going into it again.
Yes, absolutely. Yeah.
Tim, and the risk here is serious. I mean, the suicide rate is palpable with manic depression, with bipolar disorder.
Yeah, sure, Norman. The Diagnostic and Statistical Manual of Mental Disorders, the 4th edition, puts the suicide rate for bipolar 1 at 10 to 15%. So 10 to 15% of people with bipolar 1 will complete suicide, so it is quite high.
And Lynn, before we get on to bipolar 2, is the pattern of presentation any different with bipolar 1 in Indigenous communities?
In the remote Indigenous communities that I work in, we often see the depression much more than what we'd see a elevation or a manic sort of style. So we'll talk a bit later, I guess, about how you diagnose it, but we're not diagnosing it nearly as much in the very remote communities because there is so much concurrent depression. We have had some episodes of psychotic depression, but we're not sure whether that has led on to a bipolar diagnosis or not.
And Mike, your impression as a rural GP of how it presents in rural areas, is it any different, or is it more severe or later diagnosed?
Rural people are often more resilient, and they have to be because of the lack of resources, and so sometimes the presentation can be late. And we as GPs have got to be quite intuitive because depression is reasonably common, a bit like anxiety. 20% of the community may experience that during their lifetime. And we do know that bipolar disorder can be missed, and people can see 4 GPs before the diagnosis is often made. So we do need to be intuitive about thinking about the possibility of bipolar whenever we see someone with depression.
And Paul, it can take up to 10 years. I mean, people say the average is about 8 years before you're diagnosed. It's extraordinary.
Particularly with type 2 bipolar disorder, where the periods of elevated mood are much milder.
So let's just describe, bipolar 2 then.
Bipolar 2. So bipolar 2 is less severe, particularly the elevated mood. The depression may be almost as severe, but you don't become psychotic in type 2 bipolar disorder. And most people would say the periods of elevated mood are in fact mostly enjoyable. You have a lot more energy, you are sharp and clear and focused, you can achieve a lot, you can multitask. Obviously it can go a bit further than that, you can get yourself into trouble, spend too much money, but it's overall not an out of control experience.
So in the early days it'd be hard to tell them apart?
So when you say hard to tell them apart, it'd be hard to...
1 and 2?
It may be because the depression is usually the commonest presentation in type 2.
And is it as dark a depression as you get in type 1?
Well, in absolute terms, not as much. You don't become psychotic, but it is pretty severe, and most people complain bitterly about that depression.
And there's this oscillation which is quite rapid. So in bipolar 1, you describe things that happen relatively slowly. They change slowly. But in bipolar 2, I mean,
much more rapid.
How rapid?
Well, particularly going from elevated mood to depression, people commonly describe it as crashing into depression. Even though the elevated mood, well, sometimes people say it only lasts hours, sometimes it'll last a day or 2 days, but then the change into depression is quite rapid. In my experience, not as fast going the other way.
From depression to elevation?
Yeah. And in fact, I mean, the thing to emphasise is that you can have periods like this, but you can have periods of normal mood, or more commonly, you have periods of mild depression. So it's a common pattern in type 2 to be mildly depressed most of the time, short periods of up mood, slightly longer periods of depressed mood.
But not often happy.
Not often, well, what we call normal mood. The common statement is, I don't know what normal is. That's not everybody, but...
And what sort of age does all this start? Because people, have this debate about can you diagnose bipolar in childhood, adolescence?
Certainly type 2, the pattern, or if you look at it retrospectively, people will report mood swings certainly in their teens, even early teens, occasionally in their childhood. Not saying it was diagnosed at that stage. So it's often type 2 starts very early in life, probably type 1 a little later. The problem is, of course, that in adolescence, the periods of mood swing, the actual ups and the downs, are often quite short, a day or two. And that makes it very hard to confidently diagnose it.
And it sounds to me as if the line in the sand between this and, say, a cyclothymic personality that we used to describe, the up and down kind of personality, or even some aspects of borderline trait, you're almost describing here, where very hard to unpick. I mean, you're nodding, Lynn. I mean, you've obviously tussled with this yourself.
Yeah, no, I agree. It takes a long time to actually work out a diagnosis, and I think you need to build up a relationship with a person to actually, before you can actually have a definitive diagnosis, and it's difficult to do that with an adolescent on 1 or 2 visits. Would the others agree?
Oh, certainly. And with adolescents, you would rely on, in fact, even with adults, with the type 2 bipolar disorder, it's often very useful to have a family member, because they're seeing what the index person is from the outside. This index person may be thinking, oh, well, I've certainly seen it. Elevated mood, a few hours. No.
So, to what extent do you see coexisting personality disorders with bipolar?
Well, they certainly can be present together, but obviously it comes into the differential diagnosis of bipolar. People are protective of the highs, that they enjoy the energy and the creativity in bipolar too, and so as Paul said, you really need to talk to the family and the people around them to try and elucidate some of those signs.
Of course, Tim, while people get addicted a bit to the highs, they don't fully appreciate that overall their productivity is low. And when people go into treatment, they're relieved of this cyclical, the cyclical process that they've been going through, they suddenly realise how unproductive their lives were.
Sure. In fact, a big part of early treatment can be psychoeducation around just those sorts of issues. And part of the problem, as Paul and Mike have alluded to, that the highs are very compelling. They're very kind of attractive, and some of my colleagues in the UK have been capitalising on that and looking at the manifestation of a kind of distress that comes along by being exhilarated by the high, but also dreading the crash that you think is going to come just around the corner.
So they get phobic about the crash?
Well, certainly very, very worried, or almost kind of predicting that it's not too far away.
Male-female split?
Type 1, probably fairly equal. Type 2, there's a predominance of females.
Is it different biology?
That I don't think is clear. Both conditions are seen as having a genetic component. Certainly if it's very common to get a family history of mood disorder, not necessarily bipolar disorder.
Don't forget, if you've got a question to ask, send it in to questions@rhef.com.au, or you can phone in on 1800 817 268. You can text to 0408 408 932, and you can fax to 1800 633 410. So just send in your comments or your questions as we're talking. The risk factors, I mean, for example, with schizophrenia, or at least psychosis, cannabis, amphetamines, drug use are risk factors. What about bipolar disorder?
In terms of cause, really the only established risk factor is family history of mood disorder, particularly family history of bipolar disorder. Obviously, in the management of the condition, the risk, substance use, alcohol abuse, lack of compliance with medication or poor compliance with medication or adherence are all risk factors in the management, the established diagnosis.
And how does the family history work? How strongly linked is it to genetics?
It's very unclear, you know, what the percentage of people with family history when you're diagnosing. I mean, clinically we would say it's quite high, probably 30 to 40%. And this is just from family, like the
so 30 to 40% of people with bipolar disorder have a close family relative.
They can report a family history of mood disorder.
I think it's probably even 50%, Norman. 50% of people with bipolar disorder will have a first-degree relative with a mood disorder.
And the story about creativity, myth or reality?
No, that's reality.
So they tend to be more creative, they tend to be a bit brighter, they tend to do better in exams and have higher performing. So this all makes it pretty difficult for the poor pharmacist to be expected to detect somebody in this sort of problem.
That's true. As a pharmacist, we see these patients often fortnightly coming into the pharmacy. So we have an opportunity to build a relationship. And we have software in place in our dispensing program to check that progress.
So tell me about the treatment differences, if any, between bipolar 1 and bipolar 2. In other words, the practical implications of making that diagnosis.
Well, in terms of what you would, if it was a first-time diagnosis for type 2 bipolar disorder, what we at the Black Dog Institute would advocate is a particular mood stabilising medication, lamotrigine.
So that's an atypical antiepileptic?
Yeah. Whereas if it was a first-time diagnosis of type 1 bipolar disorder, we're more likely to advocate lithium carbonate, obviously the original mood stabiliser.
So is there a randomised controlled trial evidence to back up this belief you have at the Black Dog?
Not that clearly, no.
So it's a bit of groupthink, is it?
A bit of groupthink. But overall, I mean, it's based on, you know, there is some evidence, but I wouldn't say it's a randomised controlled trial. But lamotrigine is overall better tolerated than lithium carbonate. Fewer side effects, no need for the blood monitoring, and doesn't have the same narrow therapeutic window.
But Daniel, that's off-label. It's not been approved for use in bipolar disorder.
That's right. So lamotrigine often in a pharmacy, especially in a rural community and anywhere in Australia, it's off-label, it's private. So the customer, the patient has to pay for that and it's not covered under the PBS. So that's a big cost to their lifestyle.
Lynn, we've been talking a little bit, we skirmished a little bit with the cultural interpretation of bipolar disorder. So we have a view of it in the general community. It is stigmatised, but is there a cultural view of it which might be different in Indigenous communities? Can you generalise?
I don't think that's been explored. We're still, in the remote Aboriginal communities that I work with, we're still actually trying to explore the language of mental illnesses, and that we're still talking about how we describe symptoms and how they might describe symptoms, so we don't have a common language yet. And usually the diagnosis is made by white practitioners, by myself, what the family and that are distressed with, and I'm sure that people in rural communities find the same. The family's distressed by the behaviour and how that impacts on the whole family group. They just want something done about the behaviour. I think some people like a name for the behaviour, but it's certainly not described. It's usually in the manic state that's described to us, and it's described more that people are distressed by the behaviour people are showing. It's so abnormal, it's distressing the whole community.
Tim, describe these, if not subterranean, but these, this trans diagnosis. We've been talking about diagnostic categorisation. God knows what DSM-5 is going to come up with here. I mean, actually, before I get on to Tim, do we know what DSM-5 is going to say about bipolar disorder? What's in the draft? Is it going to change much?
Well, I'd be reluctant to comment on it because it's not published.
Right.
I don't think in the end it'll be that much different.
I think they're talking about expanding it to a bipolar spectrum disorder is some of the talk around, I think.
Yeah, but
job for life.
wait for the final publication.
Tim, you're not so obsessed with the diagnostic categories, more with what's going on with the individual. Just describe this different way of categorizing or looking at the underlying issues that people may have that are common across bipolar disorder.
Sure. Well, there's a couple of different ways of looking at things. One is to focus on symptoms and to try and understand those and to reduce the extent to which they happen. And another approach is to try and look a little bit at what's going on behind the symptoms. Because with almost any symptom of mental health disorder, you could find people in the general population who have the same behaviour pattern but aren't bothered or distressed by it. Voice hearing, for example, is quite common in the general population, but the voices that people hear in the general population, they're not generally distressed by to the extent that someone who's experiencing a psychotic depression or say schizophrenia is. So one approach, there was quite a large systematic review done by some colleagues in the US and the UK looking at the processes that might go across disorders or across diagnostic categories, so that might be transdiagnostic. And things like across a lot of different diagnostic disorders, we know that sleep is often implicated in their problems. Things like experiencing a loss of control or being out of control of either your thought processes or behaviour tends to be an extremely important one as well. So one approach is to look at these transdiagnostic processes and to address those rather than the symptoms.
Because they can be a barrier to rehabilitation and recovery as well.
Yeah.
And we'll talk a little bit about how you might approach that therapeutically. But let's, to challenge ourselves, go to our first case study. Sam is 27 years old. She's a teacher and she's recently moved, Mike, to your country town. He's come to the practice accompanied by his wife, who's concerned about his current state. She describes him as depressed, feeling little enjoyment in his life or work, lost his appetite, disinterested in sexual relationships of any kind, and talks of feeling isolated and worthless. Sam confirms his wife's description and adds that he's frequently haunted by suicidal thoughts. So ignore the fact it's a program of a bipolar disorder, Mike.
Thanks, Norman. There are several key things in this presentation that we need to take heed of. Firstly, his wife has come in. That shows us two things, that it is serious and how much longer he would have taken to come in by himself is a moot point.
And he's got support.
And he's got support. So they're two critical things. It certainly looks like a diagnosis of significant depression upon first presentation of those symptoms. And the complexity is that there's some suicidal ideation. So we need to address each of those things. And I think as GPs...
But there's nothing there to indicate he's got bipolar disorder of any kind.
No, not in that. That could be a straightforward unipolar depression. As GPs, I think we've got to be intuitive that anyone who presents with significant depression, we should be thinking about excluding bipolar disorder.
So how would you do that?
We need to take a further history. We need to find out how long the depression's been going on, whether he's had previous episodes, whether they've responded to treatment, how severe they've been. We need to ask some critical questions around whether there's been any mania or hypomania, an excitation of mood, energisation, creativity. And I think we all need to have a specific question that can lead into that, more along the lines that in the times when you haven't been depressed or you haven't been feeling entirely normal, have you ever felt energised or wired up? Looking for elevation of mood and that extra energy. And some people will be protective of that. And of course, the good thing is that his wife's there, so you've got the opportunity to ask her as well.
Can I just jump in there? I just want to, I think it's great having family involved to the extent that they can, but at this early stage I don't think we should discount the possibility that fractious family relationships could actually be a significant stressor, and there could be all sorts of reasons why it's been at the wife's initiation that the husband has come along after they've moved to a small town. So I would, in this assessment phase, I'd want to spend at least a little bit of time talking with Sam on his own to get his perspective on the problem and to make sure that he was, it was at his discretion.
So you're forging
that
a relationship with him as well, independently. So if he wants to divulge anything you can?
I think we're understanding that this is going to be a complex process. It's not just going to be today, it's going to be getting through today and doing a risk assessment to unpick about whether there's any intent to the suicidal ideation, documenting that risk assessment, and then he might even need hospitalisation. We haven't got that far on the history. But the beauty of general practice is that we can make time the next day to allow further expansion of history and seeing him by himself.
So as a nurse practitioner, Lynn, what would your approach be any different?
No, I'd work on the same thing. If somebody came to see me with this sort of presentation, it'd be nice to see them both separately. It may not be appropriate in the first thing. And as a nurse practitioner, I'd certainly be consulting with the GP or the colleagues that I work with this sort of presentation, and particularly with suicidal thoughts. You'd want to consult and share that responsibility so that we can make sure you are offering the most appropriate treatment.
Well, how does it work in a consultation with an Aboriginal family where it might not just be the wife that arrives, it might be the auntie, or particularly if it's an adolescent. So there might be 3 people in the room. How do you actually get space to have that one-to-one conversation?
You often don't, and it's not always appropriate. In the remote Aboriginal
because it's cultural safety in the family around you.
That's right. You work with Aboriginal health workers. If you don't have Aboriginal health workers to guide you, then you want a senior Aboriginal person to tell you what's appropriate for that person and that setting. If you don't have all that, you have to acknowledge that your way of looking at something might be different to their way. And certainly confidentiality and seeing a person on their own just may not be appropriate. You may actually get all your information from the people around that person and have to make a risk assessment and a decision on what those people are telling you.
Paul, what would be your approach here?
Again, that would vary depending on the circumstances. Obviously, I'm not seeing people in a primary care setting, so if I'm seeing them, they've been referred by somebody and it seemed that there's some significant problem. I invite the person in if they're in a waiting room, and commonly if they're accompanied by somebody, they'll either say, you go in yourself, or can I come in, or what do you think? If they ask me to make the choice, they say, well, look, to the person, the index person, what do you want? I personally prefer it if there's a family member there, that they come in, certainly for at least part of it, because as I say to them, I can tell the index patient X, and if I've got to repeat it to you, I won't repeat it exactly, and so it's better you both hear the same story. That's my view.
And your question about, I mean, one of the messages that we're hoping that people take away from this is that everybody you see with depression, you just ask 1 or 2 questions just to check on elevated mood. What are your questions that you ask?
Well, in type 1 bipolar disorder, often you get that history somehow. In type 2, it can be much
You don't
more.
have to seek it, it comes.
No, I mean, I was rung by a renal physician one day and said, I think your patient's got bipolar. If a renal physician can diagnose it, it's probably right. Anyway, but what I would say is, look, have you ever had, when you think back over your whole life, have you ever had a period as short as a day or even less where your mood was distinctly different? It was not just good, it was better than good. It was actually a bit elevated, and that time you felt very positive, you felt very confident, perhaps you needed less sleep, you had more energy. And putting it like that and adding something like, and you weren't out of control. Just trying to get at if they thought this was, a possibility. And then if you get a positive answer, then you try and refine that, you explore that a bit further.
And Tim, your approach to assessment?
Well, very similar. I'd be wanting to get a picture of why this chap has presented at this time with this kind of history going on. I think it's significant that he's moved to a small rural school, so I'd be interested in that. Was there something that he left behind at another town? Was he having an affair in another town that he's left behind and moved to a new location? I'd be wanting to know about his job, how satisfied he is with that. Have these sort of things happened before, and what was the course of them when they did, and what was his wife's role in that? How did she support him in those previous instances.
Paul, tell me about the mood assessment program at the Black Dog.
Mood assessment program is available to all medical practitioners and all psychologists in Australia. And fundamentally it's an online structured questionnaire which generates diagnoses in mood, bipolar, unipolar and what we call non-melancholic or non-biological depression, anxiety disorder diagnoses and personality traits. And it's a guide to, although I've used the term generates diagnoses, it's a guide to diagnosis. So the gold standard is always clinical diagnosis, and that's accepted around the world. This can highlight certain symptoms that the person may not tell you in a face-to-face interview. It may be misleading. And it's, as I said, it's online. If you register as a psychologist or doctor, you're given an access code which you can hand out to any patient, and the report then comes back to you.
Lynn, when you're dealing with Indigenous clients, is there a particular concentration of comorbidities? People have got coronary heart disease, they've got diabetes, and which in their own right create a background for depression.
That's right.
So to what extent do those comorbidities make bipolar disorder worse or bring on episodes of either mania or black depression?
Well, we don't know. There's just not enough work being done, so we just don't know what extent they are. We do know, like you said, that the Indigenous population has got a lot more stresses and grief and losses which predisposes everyone to depression. And we don't, certainly in the setting that I'm working in, we're not getting enough reports of mania to actually work out that diagnosis of bipolar. So, yeah, I can't answer whether those will trigger or predispose people. And I think you're talking earlier, the only thing we really know is really family history. That's the only thing that we really do know can predispose, or is it makes you more likely to have end up with a diagnosis of bipolar.
Mike?
Yeah, I think there's certainly documentation around the anxiety disorders being comorbid with bipolar disorder, particularly OCD, obsessive compulsive disorder, and PTSD, post-traumatic stress disorder.
But we talk, when people with chronic psychosis, say schizophrenia, you talk a lot about stress and having to minimize stress because stress can trigger, a relapse. True in bipolar disorder as well?
Well, I think, as has been stated, we know that most people have got a genetic predisposition, and then if you superimpose on that significant life events that are somewhat catastrophic or involve loss, and particularly if they're sequential, I think that can certainly lead to the more likelihood of precipitating mania or particularly depression.
On further questioning, it appears that Sam has had earlier episodes of major depression, and he also reports a period some years ago when he became quite restless and agitated, not sleeping at night and dropping out of university for a few weeks. He also gambled away quite a lot of money during that time, but he did not seek medical help. Now the story is revealed, Paul.
Well, let's say it certainly increases the likelihood that this man has type 2 bipolar disorder. That is described as a single episode, and you'd want to, but that gives you the lead into, or the trigger to ask about other episodes, what was happening in that, what his mood was, and has he had similar previous or subsequent episodes. Obviously, if you've got a history of recurrent periods of elevated mood, yes.
Mike, you don't have a psychologist in town, you don't have a psychiatrist. You've got a lot of experience yourself, but who's going to help you out here? This is not getting any easier, this case study.
I think it's very important in whichever rural setting you are to have a network and a team about you, because we know that the outcomes are better for multidisciplinary team care for people, particularly with mental health disorders. So whatever you've got locally, I think you try and utilise and bring those people involved in the management. I think you try and you have a network about you as well, whereby if I've got a relationship with Paul as a psychiatrist, if I'm not sure, I'm able to ring or at least make some contact with Paul, or we've got the facility for telehealth and perhaps setting up a telepsychiatry consultation.
Now, if you hadn't this part of the story and you hadn't asked the question about elevated mood, but you had somebody with quite bad depression, which is the initial story we gave about Sam, you'd have whacked him on an SSRI, wouldn't you?
Well, it certainly would have been the temptation to do so, because that's pretty normal standard treatment for significant depression.
But Paul, some people say that can kill you by putting them on an SSRI. That's a dangerous thing to do, to miss bipolar disorder and put them on an SSRI. It can make them worse.
Well, yes. For a small number of people with bipolar disorder, an antidepressant will trigger a period of elevated mood, but it's relatively small. I can't give you a percentage. I don't think there's been...
So you're not taking a big risk?
Not taking a big risk, no.
So what are you going to do for him now?
Well, I mean, knowing those sorts of things, if you're suspicious, you may start with a mood stabiliser to at least perhaps counter the effect of that mood elevation with the antidepressant. I think one of the critical things, particularly in rural areas, is to develop a trust and a therapeutic relationship with the patient, because you're going to be seeing them fairly intensively for some period of time.
So you could rush in too quickly just to get something in, but ruin a relationship that you know is going to have to be maintained, and you're going to give Daniel a problem with his adherence.
If you dive in with a therapy quickly that hasn't been well thought out, and there are a lot of side effects or creating problems, you've lost ground. So I think you've got to be fairly careful about your approach and develop that relationship.
So Daniel, talk us through some of the medications that are out there.
Usually we see in pharmacy mood stabilisers, so we're looking at lithium carbonate, sodium valproate or carbamazepine. Also we see antipsychotics such as risperidone, quetiapine, aripiprazole, Solian and olanzapine. So that's all seen at a community pharmacy in rural areas.
And what about in the less acute situation, particularly with more depression?
You can see any type of antidepressant being prescribed by the doctor or the specialist, and you may also see in certain instances a benzodiazepine, or in mixed episodes you could see sodium valproate, which can be used in therapy.
And of course lamotrigine. Well, let's go back to that first slide there, Paul, and talk us through just the relative effectiveness about some of these medications, because some of them are relatively controversial, and some people believe they don't work.
Well, the mood stabilisers, which you've listed on there, are lithium carbonate, sodium valproate, carbamazepine, and we'd also add lamotrigine, are all mood stabilisers, of which carbamazepine is now the least favoured.
Because of side effects?
Because, well, less effective, and also side effects. Of the next lot, the olanzapine and quetiapine I would call the sort of second string mood stabilisers. Their advantage, often they do have a mood stabilising effect, but the big advantage in acute elevation of mood is that they're quite sedating. So it's a way you can bring a very excited person into I hesitate to use the word into control, but where they've got more control over themselves, and you can deal with disturbed behaviour. Sometimes they're used in combination, especially in the acute situation. Generally though, if you've made a diagnosis, primary diagnosis of bipolar disorder, you want to try and put that person primarily on a mood stabiliser.
And what's the story with lithium, Daniel, in terms of side effects and how you've got to monitor it?
The thing with lithium is it has a very narrow therapeutic index, so the range that you need to have is between 0.4 and 1 millimol per litre in the blood, and side effects can be experienced at 1.5, which is quite close to that therapeutic range. And side effects can deter that patient from taking that medication ongoing, which can lead to rapid cycling of the bipolar.
How do you normally institute lithium? Right.
Carefully and slowly, because the effect of lithium is going to take a week or 2 or 3 to actually be therapeutic. And I think you have to educate the patient, and as you heard Tim say before, one of the mainstays of treatment around bipolar disorder is psychoeducation, and particularly around the drugs, to let them know what to expect and to always make yourself available if they've got a question or around a side effect.
So what's the role of CBT, Tim? Cognitive behavioural therapy.
CBT, there's been a number of trials, randomised controlled trials with CBT, and the results, I have to say, aren't overly impressive. They're okay, but they're not impressive.
Not as good as unipolar depression?
Well, no, certainly not as good as the evidence base for unipolar depression, but it's an expanding field. There's been some exciting work, I think, from David Castle and his colleagues in Melbourne, who've looked at a collaborative therapy which includes psychoeducation, as Mike mentioned, as well as CBT and family therapy in a kind of a collaborative approach where the patient is at the centre of the care and kind of manages the team that they're involved with and can kind of...
So it's helping the people around them as well, around the person
Absolutely.
as well as the person,
Yeah.
a bit like family therapy for eating disorder, for example.
Yes, and that's been, they've had a randomised controlled trial of that in natural community settings and found good results with that. So there certainly are good options coming forward for...
And in terms of CBT, you know, there's various kinds of CBT. There's various evidence-based psychotherapies for unipolar depression, like interpersonal psychotherapy and so on. Is the same range tried in bipolar, or is it a more narrower spectrum of things that you do?
There's probably similar things that have been done or are being done, but they haven't been tested to the same extent. So the similar CBT techniques that you would use with unipolar depression, you could try with bipolar depression, and similar things around recognising triggers, recognising signs of relapse, those kinds of things, problem solving, simple things around sleep hygiene, relaxation, those kinds of things would all be important in a psychological approach. And
if they're in the middle of a psychosis, can you do anything at all?
There's been again a small amount of work done through in various places. Doug Turkington and some of his colleagues in the United Kingdom have done some work looking randomised controlled trials looking at the use of CBT for psychosis, and there's been some promising work coming through there. But again, when a person is in a floridly psychotic state, I think the first thing to do is to kind of stabilise the state. The basis of cognitive behaviour therapy is to work on cognitions, and if they're out of whack, then it's important to use whatever you can to stabilise those.
So Lynn, describe the team approach and how that evolves. So what we're evolving here is that story of the team approach where you mood stabiliser, stabilise the mood, and then you bring in the other people involved. How does it work in an ideal circumstance?
Well, the way I envisage it works, they've gone to see the GP, and he's actually started them with medications. Pharmacist is actually helping them manage that. With a bit of luck, you've got a mental health nurse around who can also help continue on with what Tim's talked about with the psychoeducation, talking to people about this illness so that they understand it is an illness, and working with the medication, helping with adherence. The other part of the team is like the psychologist, maybe through the ATAP scheme, but you might have a clinical psychologist. You can also use, in a lot of rural communities, you may not have all these professionals, but there may be non-government organisations or other groups such as church groups and what have you that can provide support for the family and the carers, or there may be carers groups, and you really need to include them as well. They are part of the team, because this person will go home to a family and that family will need support because that family ultimately looks after the person.
We've had a question in, Daniel, it's directed at you. It comes from Irene, a general practitioner at ISA. Patients often do not adhere to medication. Why is that, and how can we improve adherence in this difficult situation?
That's a very interesting point. 50% of medications are not taken, and that's across all disease states, for a variety of different reasons. In this particular case, it could be that patients like that elevated mood and they don't want to stabilise. So as a pharmacist, we have dose administration aids where we can put into a Webster pack the medications for the patient. And
so that helps elderly people who are losing, who don't necessarily, who've got a bit of cognitive impairment. Does it really help somebody who has got bipolar 1?
It can help them. Another option is to sit down with them to do a med screen printout and to explain the medications and sit down with them to see if they have any questions in regards to why they're not taking any medication.
So what's the conversation you have when they say, I don't want to get rid of my highs?
Usually I ask them if they've had a chat with their general practitioner to see how that has resulted, and try and encourage them to, reinvigorate that conversation.
What do you say when they say, I'm at my best, I play the guitar better than I've ever played it before in my life, which may well be true, or at least they think it's true anyway.
I think one further point is, particularly in Sam's case, he's got a supportive wife, and that's where medication compliance adherence can help, where you actually, the wife can, or the partner can also help out with hopefully ensuring the medication is actually taken.
But that creates its own stresses and strains, because she becomes the Wicked Witch of the North.
She might. But if she can keep him stable, then I think that's going to have better outcomes for the family and the relationship.
What's your spiel when they say, I don't want to get rid of the highs, they're too good?
I think what my approach, and I've dealt with quite a few people with families with bipolar disorder, and as Paul said, there's a slight preponderance of females, and one of the activities that females do often is go out on a spending spree. And you look at do some CBT.
They do that anyway. They don't need a DSM diagnosis for it.
But this is a couple of $1,000, well, in one day. But that may not be unusual for some people. But in rural communities, that's obviously a little bit different.
Beyond the budget.
So it's looking at what the result and the outcome is of that excess mood, that energy, the overspending, and what effect that has. And it takes time, and you've got to have a good therapeutic relationship. But if you point out what sometimes the poorer outcomes are from that particular elevated mood state, then that you've got some hope of trying to modulate that. It's not easy, though.
You want to comment, Paul?
My line is, if you're going to get the highs, you're going to get the lows. You can't have one without the other. Obviously, I get that request, Doc, just fix my depression, I'll deal with the highs. But
and of course, bibliotherapy can work too, because you can read about Stephen Fry's accounts, with Spike Milligan and so on, and they all talk about their improvement, overall when they actually get rid of the highs, and how they feared that and life was better. Now, Sam has been on lithium, thanks to Mike. 6 months later, though, Mike is called to the house. Sam's standing on the roof saying he thinks he can fly. The police are there and are there as well with the flashing lights. This is a disaster.
A difficult situation, and a lot of risk attached to, obviously, to Sam being on the roof. So I think, again, we need to have a team approach to this. The police are there.
And you're relying on the police having been some police are fantastic in this situation, and they're a forgotten member of the team.
Indeed, and some can be a little bit aggressive in perhaps what their approach might be. So you need to take some time. Don't rush. There's a significant risk, and we don't want
people do die,
2 people on a roof and falling. So yes, we need the ambulance there. We need some trusted people that Sam can relate to, that we know he can relate to, whether it's his mate at the football club, whether it's someone from school, whether it is his wife. If I happen to be the GP on call, but I'm not his regular GP, it may be better for me to go and bring the other GP in if he or she is happy. Paul,
what's the role of restraint here?
Well, when he's on the roof, probably nothing. You are trying to take the approach that Mike is suggesting, is that you have a team, you take your time, you try to appeal to this person to literally climb down off the roof. You might have to help him with a ladder or something, because you don't want him to hurt himself, but you don't want to, unless you really have to, send somebody else up on the roof, because that's one threat.
And you can penetrate the psychosis enough to do
you
that?
can, yes, yeah. I mean, I'm not saying it's possible in all cases. Obviously, there's been some dramatic situations, but yeah, mostly you can.
So you've just got to get the stress levels, everybody's stress levels down.
Everyone's down, and try to get himself off the roof.
We've had another question in from a general practitioner in South Australia asking what's the role of ECT in bipolar disorder?
Look, it can be used in the depressive episodes. That would be the most common application of it, where usually where despite good compliance with medication, for whatever reason, the person's become depressed and obviously usually severely depressed to the point where they at least need a period of hospitalisation. And ECT in that sort of situation would usually get them out of that depression very rapidly. But this is in someone with an established diagnosis. Very, very occasionally in someone who has mania. And I don't mean hypomania, I mean mania, who is just not responding to any medication, is in hospital, you will use ECT to try and terminate that. That's rare.
And that's another question we just had from a general practitioner in Victoria, which is what's the difference between hypomania and mania?
Well, the intensity. Mania is a much more severe form of elevated mood. Not always psychotic, but really a real sense of being out of control. Compared to hypomania, which, as I said, most people would say is pretty enjoyable.
Rosemary is 37. She's married and the mother of 2 boys aged 14 and 10 living in a small country town. She presents with a history of recurrent and disabling depressive episodes. And a few weeks prior to coming in to see you, Mike, she became severely depressed, had difficulty getting out of bed, crying spells and suicidal thoughts. She also describes a history of mood swings for many years and says she's anxious that this is about to happen again. There is a family history of mood swings in both her father and his mother. And Rosemary has little family support. Marriage is under strain. Husband is frequently on the road as he's a long-distance driver. Mike?
Well, another complex case, Norman. We're getting a few more clues with recurrent depression that obviously perhaps hasn't been treated fully or perhaps hasn't responded. We've got some suicidal ideation, we've got some isolation, and we've got some talk about some elevated mood. So there's a little bit more of a clue that this may well be perhaps bipolar 2. She's also female, slightly more females than males, and she's in the age group where it certainly fits. So I'd be thinking of certainly asking some more of those searching questions, finding out a little bit more about the depression.
And would you use different medications given that Rosemary's in childbearing years?
Well, we obviously have to be careful, and it comes to a risk benefit of obviously finding out whether she wants any more children, is prepared to have contraception so that she doesn't, and we can continue medications that might have some teratogenic possibilities or probabilities.
Now, in schizophrenia, estrogen can help. Can it help in bipolar disorder?
I don't think the evidence is clearly established. It would probably may be of assistance in postmenopausal women, so hormone replacement therapy. I mean, if at that time, going through menopause, you had established bipolar disorder, became more unstable, assuming there were no other contraindications, that might be an adjunctive therapy you might consider.
And given you might want to bring in a psychologist like Tim and so on, how does ATAPS work? Just remind us.
The Commonwealth Government fund ATAPS, access to psychological services. They also fund the Better Access program. The funding through ATAPS used to go to divisions of general practice and now goes there sometimes via the Medicare local or to the Medicare local. Better Access, a GP can do a GP mental health plan, and
there's a limited number of visits, what, 12 or something like that?
At the moment it's 12, and I think from the 1st of January it drops to 10 visits so that they can see Tim. A lot of divisions of general practice will actually have psychologists on their payroll that hopefully there won't be a gap involved in any of these therapies, but referring privately there may be a gap.
You've got a different model in Alice.
Mm-hmm. The public mental health service in Alice Springs provides, in the community mental health team, provides a psychology clinic twice a week, which I run. I work closely with the psychiatrists there in the public mental health service, and it's a service that's free to the people accessing the mental health service, and it's not capped because I'm salaried. So it's kind of I guess another way of looking at offering psychological therapies to people in rural and remote locations where there might be a shortage of private practice psychologists.
How do you, so if she goes on lamotrigine, if she was got bipolar 2, how would she afford it? I mean, this could be quite expensive for her.
In this instance, it would cost a couple of $100 a month. So she would have to somehow...
That's a lot of money for a
That's
family
right.
that doesn't have a lot of spare.
It need to be in the budget, and if it's not in the budget, it could be a factor leading to poor adherence. You know, this month I can afford it, next month I can't.
So you've certainly got to work that through. Would she respond to cognitive behavioural therapy, do you think?
Oh, I think she'd be a good candidate. Yes, I'd certainly want to at least offer her the option, and I'd pick up on one of Mike's points that a lot of GPs, I'm not sure of the numbers, but a lot of GPs are trained in cognitive behavioural skills as well, and could start that in the first instance.
And what about CBT in Indigenous communities, Lynn?
My understanding of CBT is that you have to be motivated to engage in it, and also that there's a proportion of homework. The population I'm looking after, English is their second language. A lot of people are not literate in their first language, let alone in English, and they have so many other comorbidities and social issues going on that it's really not a high
Engagement with CBT
priority.
is a real issue.
Yeah. But apart from the fact there isn't a lot of practitioners, we're going even more rural. There's not a lot in rural areas, even less in remote areas.
We haven't got a lot of time left, but I just very briefly want to touch on her son Jack, who's 14, that she's worried about. He's insolent at school, he's often difficult in class, he's withdrawn at times, isolates himself. She recognises that those were things that she had at the age of 14. Can we diagnose bipolar 2 in Jack? Paul?
We can't on that history, no.
Can we ever?
I believe we can if we got, again, a clear history of recurring periods of elevated mood, clearly elevated mood. And of course, it's harder to distinguish or harder to diagnose in
Because it's almost normal in adolescents.
Because
to be up and
adolescents have
down.
mood swings, and you know, there's adolescent angst, or that's what I refer to it as. And the bipolar disorder often has shorter periods of both depression and elevated mood. But if you've got a very clear family history of bipolar disorder, and I've seen it, where one parent has bipolar disorder and a 13-year-old girl, I think it was her or her mother, volunteered, oh, just like Dad. You know. Now, I'm not saying absolutely that's the only diagnostic, but she had a 4 to 5 year history of mood disturbance, mood swings. Which was distressing for everybody.
And of course, this is a child you would not want to be engaging in alcohol excess or other drug use. But what other things can you do for a child who you think is evolving into a bipolar disorder?
Well, I would go back probably to what Tim is saying. You engage them psychologically. Now that doesn't have to be the psychologist, it can be the family practitioner. You want to build up their trust, you want to talk about their mood, you want to perhaps provide them and their family with information about bipolar disorder, which is readily available.
And you certainly want to engage with a child and adolescent psychiatrist even at a distance.
If you can.
Don Woods, general practitioner in Milton in New South Wales, asks, how do you differentiate between ADHD and bipolar 2 in adolescents and children? Good question.
With great difficulty, most of the
Which
time.
is really what you've just been talking about.
Yeah, except that with attention deficit hyperactivity disorder, they may have hyperactivity, but that doesn't necessarily mean they've got elevated mood.
But some people are using methylphenidate as a mood stabiliser, aren't they?
No, not as a mood stabiliser. Sometimes to augment antidepressants when you've got a partial response to an antidepressant in a clearly melancholic biological depression.
So not in bipolar disorder?
No.
Leave that to one side. So really in this case for the child or the adolescent, it's a question of watching closely, monitoring, bringing in the team and keeping a child and adolescent psychiatrist informed as a
and
general.
developing the relationship, and if you're able to, and Jack is compliant, getting him to do some mood charts and record his sleep and his eating patterns.
Very briefly, Paul, resources that people can go to?
Well,
If they want more information?
obviously I'm from the Black Dog Institute, so anybody can go to the Black Dog Institute website. There are sections on depression and bipolar disorder.
And the mood assessment program, and there's always Beyond Blue.
Yes.
And there are other sources as well, which we will have on our website. Look, thank you all very much. What are your takeaway messages for those watching, Daniel?
Ask your pharmacist if you need adherence support within rural and remote communities.
Paul?
Particularly people with recurrent depression or poorly responding depression screen for elevated mood.
We have a wide range of good options for people experiencing bipolar disorder, and we need to get better at fitting treatments to patients rather than patients to treatment in terms of the combinations of the options available.
Look at their problems, get the solutions to them. Lynn?
Look after the carers and the families. If you can support the families and the carers, then they'll help support the person that's got the diagnosis.
Michael?
Again, re-emphasising being intuitive to the diagnosis of bipolar disorder in someone who you think might have simple unipolar depression. Having local networks around you and having more distant people that you can call on for advice.
Thank you all very much. Fascinating and important. So always check on that elevated moods period, and just one quick question, only another 30 seconds on your consultation. Now, if you're interested in obtaining more information about the issues raised tonight, there are a number of resources available on the Rural Health Education Foundation website, rhef.com.au. There you can go to the Bipolar Disorder, a team-based approach program webpage, and click the resources link. We also need your feedback on the programme so we can constantly improve our service to you. Your comments are very important to us. Let us know that you watched the programme by sending us an email or a text and tell us what you thought. If you're a health professional, don't forget to complete and send in your evaluation forms, which can be found on the website. You'll receive a certificate of attendance and, if eligible, CPD points. The Rural Health Channel broadcasts 24 hours a week. To see what other programmes are showing on the Rural Health Channel this week and next, go onto the Foundation's website and click on the RHC TV guide on the left-hand side. Thank you for taking the time to watch and contribute to our discussion today. I'm Norman Swan. Goodbye, and I'll see you again soon on the Rural Health Channel.